health. We do so particularly because we have a lot of graduates in the system who want to activate their PINs every year. And for that matter, there is a need for them to have a certain points of CPD training within the year before they can do the registration to keep their PINs active. But we do it not only for people who have passed through our advanced global college, but for all medical laboratory professionals, that is technicians, assistants, and then the scientists. So we do it every year, and we usually wrap up. We are usually the last, as we are this year. I think we are about the last accredited CPD training program. So if you miss the training with us, you may have missed for the year. So it is important we know that this is the very last of it. And if we have friends and colleagues who have not participated in any CPD training yet, we may recommend same to them. The training doesn't end today. It is on today, the 13th, it will be on the 14th, the 15th, and on the 16th. So by 16th, anyone who hasn't registered and you know he or she needs it, you can kindly communicate to such a person and encourage them to register. It is very user-friendly. As soon as you register, you'll be sent a link and a receipt. You can use that link to join the WhatsApp group where information is shared pertaining to the CPD and related issues. So once again, you are welcome. And then I promise you, it's again going to be a very excellent, wonderful facilitation. We have brought to you once again very seasoned senior members of the medical laboratory that I will urge that we stick to the protocols. As you know, it is a virtual training. And because it's a virtual training, we don't see one-on-one. We don't see eye to eye. So there is a need for us to listen with rapt attention. And if we have any questions or if there are any ambiguities, we can note them. And when the lecturer is done or the facilitator is done, of course, they will give you an opportunity to ask questions to seek such clarities. Also, because it is done virtually, there are certain things that have the tendencies of disrupting the whole process. Notable among them is not putting your phone or your laptop on mute. If you don't do that, we may be tempted to hear noises and other things that may disrupt the training. I'm not sure you'll be happy with that. Also, if you have a question, if you want to have any clarity, you please wait. Intermittently, the facilitators will give you an opportunity to ask questions and also to seek clarity.
Sorry about that. I think Rumi's internet has an issue. So if Dr. Botri, you can take over and start the session. Hello, Dr. Botri.
Okay, thank you so much, Elijah. I'm really grateful. Sorry, I wasn't hearing the latter part of it, but that's okay with me now. I would want to kindly use my laptop, one of my laptops, to do that presentation in a bit, but I think I'm having some slight difficulties. Please, can you hear me?
Yes, you can proceed.
Okay, so I'm having some slight difficulties with my laptop, but in due time I'll come on it. So now I'm trying to do this presentation from my phone for now, but once I get connected with the laptop, I will switch immediately so that it will be much better, please. Thank you. Thank you. Okay, so thank you. I'm trying to share a document right now on my screen, and I don't know whether it is visible to the audience. Today we'll be looking at blood component and preparation for transfusion and its association with and practices associated with infection prevention and control. So this is going to be very comprehensive, and kindly prompt me, especially if I'm going maybe beyond my given time, so that I wouldn't take much of the time. So please, is my screen is it seen by everyone? Because I'm trying to do the presentation from. Kindly proceed.
I can see.
Okay.
I can see.
Okay, thank you. So now it has really become an essential part of clinical practice, especially in the medical laboratory science department. Our role in this whole task is to take blood from donors and store them in our department safely, so that when there is a need for them to be given to particular patients, we will deliver it to the patient. So that is to tell us that blood is really important for survival, in as much as other body organs and tissues are also kept elsewhere in other specialized departments or labs or banks. So it is not only blood that is stored for transfusion. Other tissues that, in terms of emergency, look at somebody's skin, someone who has undergone, let me say, burns, severe burns, people who have lost their eyes through accidents. All organs of the body may be required, by some patients to survive. So specialized facilities have banking system that keeps those tissues. But with regards to the laboratory, especially in a department known as the hematology, we are interested in keeping blood and blood-forming tissues. So it is not only blood, but we could also keep cord blood, though this is not a common practice. Cord blood, which is really rich in blood-forming cells like stem cells that could be used to treat some genetic conditions. And not only that, some specialized labs are also able to keep bone marrow aspirates and biopsies, also for transplantation. But the commonest of all of them is blood storage. So where do we get our blood from? The blood that we normally issue for transfusion, where do they come from? So that is what we really want to have a look at, the sources of blood. So blood centers and transfusion services are responsible for providing an adequate and safe blood supply. So once your hospital has a department known as the blood bank, it is your responsibility that the blood that comes into your department is safe, so that you will not be blamed for, inducing disease conditions in patients. Make sure your collection processes, your storage processes, your transmission processes, and the final therapeutic stage are all done in a safe manner to ensure that patients are receiving the best of these products. So in an effort to provide uniformity and clarity for determining the eligibility criteria for volunteer blood donors, the donor history. So we want to make sure that whoever is coming to give us blood, yes, we need blood because patients need blood, clinicians want blood, we are supposed to serve them. In as much as we want to give blood, we want to make sure that whoever is giving blood meets certain standards. Every person must meet those standards so that we ensure that we are not giving blood that is already, let me say, infected with pathogens, blood that is not even wholesome to be administered to patients. So there are requirements that even if you want to volunteer to come and give blood, you still have to meet the requirement. Yes, I'm volunteering. I'm not going to charge the hospital money. I'm not going to charge. It's free, but still you have to meet the requirement, because not anything that is free is needed by the hospital. We have to make sure that we avoid the possibility of transmitting infection. So there are standards. Nobody can just walk into the lab and say, my nephew or my relative is in the hospital and therefore I want to give blood. Or nobody can just walk into the hospital and say, your patient may need blood. You have accident and emergency centers. I just want to give blood. Take my blood. No, you have to meet requirements. So these are standardized requirements that people have to meet strictly for them to pass. So we always have to maintain those standards. And how do we maintain those standards? We have to start educating the public. We have to start educating the public about all these. Okay, so that brings us to the necessity to screen donors. Infection prevention and control. We want to make sure that we in our services are not providing a medium where people come with complaints. I am not HIV, I am okay. Just that I had a chronic kidney disease and I was admitted. I received 7 pints of blood and I'm suspecting that it is the blood that has given me erythro infection. We should not be let me say, the department to be blamed for it. So we have to ensure that in delivery of our services, we are providing wholesome blood. That is why these standardized procedures are there for screening. Donor screening is really important. They must meet strict eligibility criteria, and no lab man should compromise these eligibility criteria. So who is eligible? The process of determining that the donor is qualified to donate. Is he qualified to donate blood? Or is he qualified to give just even a component of the blood? Maybe there are some blood groups that are really rare. They are not common. Let me say someone will come and say, I'm O negative. The whole hospital, the whole region, you are in search of O negative. You haven't got, I'm the only one who has O negative. But still, that person must meet all the eligibility criteria. Otherwise, we cannot take the blood from such a person. So he must be eligible. That is what I'm trying to say. So in the course of screening, these are some of the processes that should be involved. The person may come to your facility, or you may even go to some institutions, churches, public places, do announcement and all that. You would meet the person. First, you need to register the person. How do you register the person? There should be records, especially for people who have been donating frequently. Some are donors. Some say, I'm a blood donor. I have my card. I have history of donating. So those people with history, those people who have even tried to donate before, but maybe for one or two reasons they were rejected. We should, in the course of the registration, we need to interrogate them to know their history, at least. When was the last time you donated? Then the person says, I donated maybe 2 months ago. When was the last time you attempted to donate and you were not allowed to donate for any reason? So registration process is quite comprehensive. I'm going to go into it. Then in the process of registration, we need to educate them. Nobody will just walk into your blood bank and then you screen them. Maybe people check HB and do this and start taking their blood from them. No, you need to educate them. The education part is really, really important. So I'm going to tell us a bit about education. So every standardized blood bank should have education material. When they come to your lab, if they can read, you have to give them education material. Tell them about why in certain cases they will not be allowed to donate. They should be educated. They should know. The lab in recent times is adopting certain strategies whereby people are denied the access to donate without the specific reason. People are afraid to tell people, this is the reason why you're not allowed to donate. All they will say is that your blood is too heavy, your blood doesn't match. But the main reason, the education aspect may be lacking. They refuse to go into details. You have to let the person know details of it. So I'm going to show, in certain instances where people would have access to certain materials to help them donate. Then you need to, interview them, check history. So there are some questionnaires. There are some questionnaires that we may give them in assessing their health status and all that. I'm going to show an example. Then physically you examine them. So the lab aspect with regards to the physical examination, we do HB estimation and all that. So I'm going to say that. So donor screening basically is too huge for the lab alone to pursue. Blood banking and transfusion services is not limited to the lab. The lab works when it comes to donation and when it comes to transfusion. The lab works in collaboration with the whole medical team. There should be a clinician. There should be nurses trained for that. So it's a whole set of team, and the lab is doing an aspect of it. So we are going to concentrate on what we do. So this is the hierarchy of services that should be undertaken in case somebody would like to donate blood. Registration, we want to know a bit of your history, especially your donation history, why you were rejected before and all that. Then we have to educate you on the consequences. We have to tell you, you want to save someone's life, but in the course of donation, there are some risks. Something could happen to you. There could be this, there could be that, but we are assuring you that there are expertise here who would, attend to you in case. Let a person know that this is not, let me say, straightforward. You could donate, you could pass out, you could collapse. Let the person. So education is really, 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 really important in that. So registration and that. Now, in our part of the world, the most common sources of blood donors are those who donate for their blood to be used by the general population of sick people. That is the most common sources of blood. So people that do mobile sessions, maybe regional, they go, yes, can you hear me? I don't know whether I am clear.
Yes, you are clear.
Okay. Okay. So okay, so I can continue. Okay, so the allogeneic kind of sources are the most common practice in our part of the world, where even if they don't know the persons who are requiring our blood, we just voluntarily give the blood. Maybe our blood may be sent to Tema General Hospital, our blood may be sent to Kolebu, our blood may be sent to Eastern Regional for use by general population. That is the most common sources of blood in our part of the world. So in that setting, when the donors come to us or when we go to them, the donor registration process includes documenting information that fully identifies the donor. So we have to know the name of the donor, where he stays, his address, certain details that will help us identify the donor. You can't say a donor came to donate and I don't even know where he stays. At least there should, that is what the protocol says. Why is it important that at least we could trace the donor to where he stays? Because after identifying certain conditions in such a patient, we should be able to take on further to educate the person, direct the person where to go. It is in the course of blood donation that people get to know that they are even hepatitis B positive. It is in the course of the donation. They might not even know. It's in the course of donation that people get to know certain conditions in them that they had no idea of. So traceability, we have to be able to take details in the course of the registration, and this information the donor will be willing to give us. Okay, so we have to know that where has he previously donated? Has he donated in the last 2 weeks? If he has donated in the last 2 weeks, then he hasn't passed. There should be sufficient time for the donor to wait for the next donation. The fact that he is a frequent donor doesn't mean he qualifies to donate anytime. No. So we have to get all that information from them. So in the course of the registration, these interrogations may take place, and then the personnel will be well abreast with that information. So correct identification is very, very important. If you cannot identify a donor, if someone says, I stay in Kumasi, I am a donor, and we don't have any record of him, then we are likely to be missing, because correct identification of a patient is essential to prevent collection from someone who is not qualified. Collection of someone who, if in Ghana, if we have that database where every donor has a unique number, if you're a donor and you come, we put your number in there, a unique number in there, then we have all your history. Yes, you have been donating for the past 10 years, but in recent time, we identified that you are infected with this. So due to 1 or 2 reasons, you have been temporarily deferred from donating. So it is really important for traceability. And it also ensures that the donor can be contacted with test results and others. So some people go for mobile sessions and they take a whole pint, a lot of pints of blood from people. All they check on the site is maybe hemoglobin. All they check is maybe your temperature. They check your body weight and HB. That's all they do. And they bleed the people, bring it to your facility. Then they come to screen the whole blood. After screening the blood, they realize some people are HIV positive. It's the duty of the facility to contact such people, because some of them need to undergo treatment. It will be unfair that you found that a donor who was willing to save someone's life had an infection, yet you can't trace them. You just throw the blood away and that is it. No, it's not fair. At least we have to be able to trace them, so that if there is a need for treatment, we would recommend it for such people. That is why in the registration process, full details, so their full name, their permanent address, where they stay, their date of birth, and other personal information are really required. If the person has donated before, at least if you've given 1 pint before, you should wait for 2 months. 8 weeks must elapse. If I've given 2 pints in recent times, you must wait for about 16 weeks. So the fact that we need blood to save other people's life doesn't mean we should disregard these protocols. So that being said, now it is not only the allogeneic type of sources of blood that is practiced. Sometimes people come to donate blood, but their blood is given to a particular relative. Their blood is for a directed patient. Maybe he's a relative and he wants to receive blood from his relative, not the general population. People have personal reasons why they do that. Maybe clinical reasons, clinical conditions. So they want to receive from a relative. So directed blood. So in your blood bank, blood should be accurately labeled. If you are a staff on duty, it is not any blood that you should give out. Is it accurately labeled? Because some people's blood are labeled. It is meant for this person in this ward. You can't take that blood and give it to an emergency case. No, his relative came to give it. So not every blood in your blood bank fridges or storage areas are meant for anyone. Some are directed, some are autologous. So some people are booked for operation and they ahead of time they have come to donate. They have bled themselves to be kept securely for them. So such blood in your fridge should also be accurately labeled so that they are not given to maybe an emergency or whoever may be in that need at that particular time. So a biomedical scientist or a laboratory scientist on duty should ensure that whatever issuing and whatever blood they are issuing is labeled so that it will not become a legal issue against the facility. So some people may also give specific components, apheresis. This practice may be found in maybe in referral hospitals. I mean, like the teaching hospitals and all these specialists. So people come to give specific component, and you need sophisticated equipment to do that. Some come to donate only platelets. Some come to donate only white cells and not. So maybe you will bleed them, but that equipment, that apheresis equipment, would take only white cells and return the rest of the blood into the people. So such practices may be found elsewhere. But in our part of the system, we mostly give whole blood and we prepare some components from it. That apheresis is not a general practice here. That is fine. So the first step is the registration step. You have to know the history of the person, where is his contact details and everything, whether he has donated before, whether he has been denied access to donate. All these details are really important. That is fine. Now, the second stage, he has been registered. He is ready to donate. You need to educate him. The person needs education. Is it your first time donating? Yes. Okay. You may be a bit tensed. That is fine. In the course of bleeding you may have rashes on you. It is normal. Your heart rate may go up. It is normal. You may even collapse. It is normal. We are trained here. There are doctors around. There are nurses around. We will be able to attend in case these things. We shouldn't lie to them. You have to educate them. The materials should tell them the risk associated with donation. Donation is not like an easy thing. So they should be made totally aware. That is why at the end of the education, they need to sign an informed consent, because I've told you everything that is associated with it. Are you still happy to donate? He says, yes, I'm happy to save a life. Then he must sign a document to show that he has given his consent. So before donating, all prospective donors must be given educational material. So your lab can follow. These are standardized documents. Your lab should have one. If you have blood banks in your facilities, your lab should have one, or create one. When they come, you should give it to them. Or when you go for mobile sessions, you should give it to them and educate them. Those that cannot read, we could interpret it in their local languages for them. That is fine. So I just copied one of the education material. It is not that eligible. You may not see, but when I give maybe the slides to you, you can read. The person must read through everything and then be satisfied that, yes, I'm ready to undergo this exercise. Okay, so that is it. So the person has read it, he's well informed of everything. Then the person must give his informed consent. Not many labs in recent times do this. Oh, he came to donate. Did he sign any document, affirming his consent? No. He must sign a written informed document, informed consent. He must sign. Issues about clinical practice has a lot of legalities associated with it. And the issue is that when there is no problem yet, we may think, it's that easy. But in event of a legal issue, coming up, any practitioner who knows these protocols will question you. And now the laboratory staffs are licensed. You may lose your license if you if you don't follow these strict protocols in event of, these things. So before donation, the donor must sign a written informed consent. He must sign. There should be a signature. If he cannot sign, he should print to affirm his consent. Okay. And for education purposes, people do research using blood donors samples. You have to let them know you are donating to save lives. But if you have another purpose for their blood, they should know that this is a teaching hospital. This is a regional hospital. We may sometimes use your sample for research, because sometimes we want to know that asymptomatic malaria among blood donors. We want to know those that HIV positive samples among donors, though they have been tested with, let me say, RDTs and test kits. So maybe you want to do your research and use PCR to test. Let the donor know that because when they find out that you have published a paper, a study conducted in Eastern Regional Hospital, and you say blood donors, 7% of blood donors in Eastern Regional Hospital, Ghana, were HIV positive. It is published to the world. And he looks at the time the research was done. So the research was done around September 2023 to December 20. I will say, but September, I went there to donate. They didn't tell me they're going to use my blood for research. They can take you on. So let them sign an informed consent. Your blood you are donating, we are in your church to take your blood. We are in the community to take your blood, but it's just to administer to patients. If you want to use for it, let them know so that they will say, okay, go ahead, use my blood for research. That is fine. So an evidence of consent must always be given. So you have registered them, you have educated them, you have told them the purpose of which you're going to use their blood. I mean, the allogenic, those that give voluntarily, that go and use it to save lives, You have educated them and all that. Now, the next stage is to know certain health history, because infection prevention and control is key at this part. Infection prevention is key. Yes, he's happy to donate, but health history, because certain risk factors may not make them qualify to donate blood. So donor health questionnaire. There are some questionnaires that we give it to them to sign. When was the last time you had sex? At least they should be able to tell you. When was the last time you had sex? When was the last time? Though some potential blood donors may lie when it comes to some of these, but at least we want to have a fair idea. So the document is used to protect both the donor. So let the donor know that the reason why I'm asking you these questions is to protect you and also to protect the recipient. It's for both sides. I want to protect you because maybe you have history of, let me say, cardiovascular disease, hypertension. I'm protecting you. Are you taking any hypertension and medication? You should be faithful to tell you yes. If yes, you are disqualified, because bleeding, you may have cardiac arrest. I'm trying to save your life. So health history, this is really, really, really important. When was the last time you took vaccination? When was the last time you took this? So these questionnaires are there. So I just put a sample here. It appears too small, but if I enlarge this a bit, they come. Are you feeling healthy and well today? Are you currently taking any antibiotic? Yes or no? They should be able to provide answers. Are you taking any other medication for an infection? They should tell you, oh, I'm taking antibiotics. I had common cold. They should tell you. So I'm treating it, but I want to donate. So these are basic questions that we use. So if they give a certain answer, that makes them, at risk or potentially at risk of transmitting an infection, or potentially at risk of suffering from the process of donation, we have to based on that defer them. So what are the kind of deferrals? What are some of the kind of deferrals? So sometimes some donors may be deferred indefinitely. Indefinitely means you are deferred, you can't donate, but we don't know when we would allow you to donate indefinitely, maybe because of the regulations that may exist at that part, in a particular season. Maybe in 2020, there was COVID-19. COVID-19 became pandemic. So if someone comes and he has a history of COVID-19, we are scared. Though COVID-19 is not part of the protocols of screening, but at that particular season, it has become a state of an emergency, like a global pandemic. Yeah, COVID-19 have been treated, but let's defer you indefinitely until further notice. Maybe regulation will say now COVID-19 is no more pandemic. Those who have been treated at home, they can donate, then we can allow it to. So indefinite deferral, and we will be able to detect that from the questionnaires. And sometimes some of the testing we're going to do. So permanent deferral, the person has HIV/AIDS, hepatitis B, permanent deferral. So some may be permanently deferred. Even if they get well in future, we'll still not be happy to take their blood. So permanent deferral is required for based on high risk behavior or positive test result. High risk behavior. Maybe you told us that high risk. So you told us that you once lived with a brother who was this high risk, who was positive for this infection. So sometimes some of these, yeah, or when we tested, you realize that you are positive for, so high permanent deferral. But temporary deferral, yes, it is recommended if the donor would be eligible at a specific time. Maybe temporary deferral, you said you donated blood last month. You have to wait. You donated 1 pint last month, 4 weeks. You have to wait for another month. You have to wait. So we are deferring you now. Go and come back 1 month later because you have to wait for 8 weeks. So that is fine. So certain conditions may let us defer some people temporarily because we want to ensure safety for patients and safety for the donor as well. So some questions may protect the donor, as I said, and some questions are meant to protect the recipient. So these are all fine. Okay, so after we have screened the person by assessing them, their history, health history, and all that, then we need to physically examine them. Physical examination, that is really important. General appearance of the body, of the person. If he's coming to your hospital drunk that morning, very drunk. If he's coming to hospital, you see him coughing. People are sitting in a queue, he's coughing. General appearance. The prospective blood donor should appear to be in a generally good health condition. Okay, so if they have taken alcohol that morning, they are very drunk. You see, some drunkards, excuse me to say, go to blood banks and donate, and biomedical scientists, laboratory scientists are happy to bleed them. That means they don't know what the protocol is saying. So they should be healthy at the point of donation. They should be really healthy. And as I said, the transfusion team is not only the lab. So if you go to a proper blood bank, you see that there are nurses in their department. There is a doctor who may be called in case of emergency and all that, and the lab aspect of it. So the laboratory aspect is that we will check for the person's hemoglobin. The reason why we want to check for hemoglobin is that if you want to take a pint of blood, okay, a pint of blood is nearly 450. Some blood bags can even take up to 500 ml. So HB level is really important. And we know that for a man, he should have 13 grams per deciliter. You know, the normal rate for men is 13 to 18. So 13, minimum of 13, and a woman 12.5. Some facilities have these HB equipment like HemoQs to measure HB. But if you should go for, let me say, mass donation, mobile sessions, people use the qualitative or copper sulfate solution. They just take a capillary blood and dip it in this copper sulfate. If it's able to sink down, then it means your HB is normal. It is averagely above 12. So they accept you. For mobile, that is fine. So HB, the person must pass. So apart from HB estimation, other physical examination exercises are done So the appearance, you should be in good health. HB and hematocrit, we do that. BP, that's what the nurses do for us. Blood pressure, I don't think that is the duty of the lab. So they have to check the person's blood pressure and temperature. The temperature should be 37, not more than 37.5. So they will also check the person's pulse and the weight. So average weight 50 kilograms, average weight 50 kilograms, and the age in our part of the world, 18 years. But now in recent times, I know people go to senior high schools to bleed them, and those kids may be around 16, 17, 18. So minimum is 18. People say 16 years. So they also, bleed people in that category. So registration, knowing where the person stays and all the details, whether he has donated, then you educate the person with materials, let them read and understand. If they can't read, you have to interpret everything to them, the process they are going to undergo. So education is really important. They have to sign an informed consent after educating them. Then health history, you have to check your health history. Maybe you're at risk of certain infections. You want to be double sure. Maybe you have certain conditions, heart conditions, disease conditions, chronic disease conditions that you trying to give may end up your life. So the purpose of that is to save the donor and also save the recipient. That is it. Then physical examination. All these are set. The patient has already given his consent. So how do we collect the blood? So if a person weighs more than 50 kilograms, blood is collected into these blood bags and they come with anticoagulants in them, the citrate phosphate dextrose adenine, CPDA, which is about 63 ml in them. 63 ml in them. So at the end of the day, you are adding blood and you are expecting to have about 450 ml or even up to 500 ml. That is fine. The purpose of the anticoagulant CPDA is to prolong the shelf life. Okay, so initially there were other forms. People used to use ACD, acid citrate dextrose, but now by recommendation, CPDA is able to maintain the shelf life for 35 days. 35 days. If you want to add other additives like adenine and saline, it could be prolonged to 42 days. That is fine. So that is the purpose of it. So you have explained the purpose of the donation to the people, and he is still happy to donate. You have screened the person. He has passed all these stages. Now, donor reactions is possible. That's to be acquainted with that information in the present, especially first-time donors. Especially first-time donors, they are very anxious. They are scared of the exercise. They don't know how it feels. So occasionally you may see them that whilst in the process of bleeding, their pulse is going higher, is increasing. Okay, their heart is getting affected. Okay, so and such apart from first-time donors, maybe always when they are trying to donate, they have an episode of that reaction. So it's frequent in such category of people, and this should be expected by the lab personnel. This should be expected by the lab personnel. So they should in the process of bleeding someone. That is why lab man cannot sit in one corner and say, I'm bleeding a person. When this happens, because it is a well-organized exercise, you call a clinician, immediately he's aware. The clinician should be able to attend to the patient in that event. Nurses should be able to attend to the patient in that event. That is why you don't have the authorization. If your lab is not practicing this blood banking and all that, you don't have the authorization to bleed a person in your facility. You don't have that authorization, because in event of these reactions, you'll be held responsible. Because if you're not trained to deal with heart and cardiac issues, that is going to cause a problem. So sometimes people will be donating, bleeding, and then you see them sweating. They become pale, they become weak. Some even finish with the exercise and they collapse. So you have to, attend to them. So what should be done in such scenarios? So in case we observe that, people suffer certain consequences in this, what should the lab man do? Or what should be done? So there are some, let me say, there are some basic practices that the lab man should do. Feet elevation. Sometimes they are clothing, they are sweating, you have to loosen them up in the course of the exercise. When they are collapsing, you have to stand them on their side. Sometimes you have to put cold and towels on them, cool them down. Okay, make sure the place is well ventilated and all that. Then you assure them, call a clinician to come and attend to the person. So that is it. Now we have successfully collected our blood from the donors. How do you process it? Now we want component preparation. Component. It is not just whole blood that we could obtain from donors. Component preparations. What are some of the processes that the blood must go through to ensure that they are wholesome? We want to prevent transmission of infection, especially through transfusion. We want to prevent any contamination, anything that will shorten the shelf life of the blood. So apart from the blood grouping that we do, ABO blood grouping, people normally do the tile method, but the recommended method is the tube. Then maybe you confirm it with the reverse if it is available. So we do ABO, we do resource grouping, which many of us are aware of. Then if the person has history of pregnancy, the person who is coming to donate is a woman. She has been pregnant before, she's been giving birth before. Because of the nature of pregnant women, maybe they are resource negative. They got impregnated by a resource positive person. So maybe because of the baby introduction in them, maybe they've been exposed to an unusual, let me say, antibodies. So sometimes it must go to that next step of screening them for those maybe clinical significant antibody that may cause reaction in recipients. And maybe a donor who has once received blood. Are you coming to donate? Yes. How old are you? 25. Have you received blood yourself? He says, yes. I was sick. I was once transfused before. So in such categories of people, grouping and cross-matching is not enough. You must do antibody screening in them to be double sure that there is no clinically significant antibody that may cause a reaction in the recipient. Pregnant woman, someone who has history of pregnancy, and someone who has history of who has received blood. Those category of people. Otherwise, many laboratories just do grouping cross matching, and that is it. They are good to go. So to ensure infection prevention, we have to undergo microbial testing of pathogens. So the commonest one, apart from the HIV and hepatitis B, we also do syphilis, Treponema pallidum hemagglutinin, or people do the VDRL. It's the same testing for the syphilis. Then people do all these testing that you see: hepatitis B, hepatitis C virus, HIV testing, and all that. In certain countries, they even go further to test for malaria and test for other epidemics that that hampers their health. In the UK, malaria is really important. They have to screen you for malaria because they are really scared of it. And malaria could be in someone for even 30 years. The parasite, falciparum, it could be in someone for up to 30 years. So even if you have a history of traveling, you've traveled to a malaria endemic area, they will not even allow you. You are deferred from donation. So in our part of the world, we are really interested in the HIV, the hepatitis B, surface antigen. And if the person has once had hepatitis, sometimes we even go ahead to test them for the core antibodies, because the core antibody tells us that you have been previously infected, though the surface antigen is not showing you are positive, but the core determination of the core tells us that yes, he has been infected before. Such a person may be deferred. You may not be allowed to even donate. Now, this is the stage where this part of testing is the stage where there are accusations that the techniques that most laboratories use is not sensitive, it is not specific, and it's not even precise. It's not even precise. In certain situations whereby one of the infections like syphilis, those who are experienced on the bench will tell you syphilis can never be transmitted through blood donation. And it's true. Syphilis can never be transmitted. The only means of syphilis transmission is through sex. So the experienced people, what they do is that even if someone gets syphilis, they put the blood in a fridge for 24 hours. And the next day, if you test the same blood that tested positive initially for syphilis, it will test negative. So if the person passed all the other tests and syphilis is positive, they put it in their blood bag, their fridge, and then the next day it becomes negative. And it's true. But the protocol says if the person tests positive for syphilis, don't accept the blood. Why shouldn't you accept the blood? The fact that he has tested positive for syphilis tells you that he has had an unprotected sex. The fact that even gonorrhea, he tests positive for syphilis, even gonorrhea, it tells you that he has had unprotected sex. Such a person is at a higher. So what method are you using to test the HIV? If someone is syphilis positive and you want to take the blood, that means you have to use PCR, one of the most sensitive. You can't use the normal kit, first response. No, because you may miss it. So in that situation, if you really want to take a syphilis positive blood, put in your fridge, and the next day you want to give to a patient, make sure testing is PCR, because that person is likely to transmit other infections like HIV. And your test as he may not be sensitive enough to detect them. So this is really, really important. This is really, really important. So nucleic acid testing is what is currently recommended worldwide, especially in the blood bank. Nucleic acid testing, polymerase chain reaction. So that when the person contracts the virus or the pathogen, even yesterday, you can detect it today. Even yesterday, because the antibody antigen test that takes longer, incubation periods for the antibodies to be detected. Sometimes 3 months before you could detect that the person has retro. So that is fine. So these are some of the basic tests that are mostly conducted on blood or their components before administering. So blood component preparation. So the commonest component is the whole blood. The commonest component is the whole blood that most clinicians really request. But this practice, to be fair, is only common in Ghana. Whole blood is never recommended for a patient. Whole blood. Why would you have to give whole blood? Is it because the person is anemic? If the person is anemic, then give what would treat anemia. Why are you giving whole blood? Is it because the person has lost, has been engaged in, let me see, an accident and has lost volume? Yes, if the person has lost volume, then whole blood, that is fine. But is the person just anemic? Paxel. So I'm going to give you various components that may be obtained from the blood. So blood and blood component. Whole blood is the whole. And the components are certain, aspects of it, like you could get platelets from it. You could get even white cells from it. You could get even the plasma from it. And even the plasma, you could get clotting factors from it. That's what people call cryoprecipitate. Clotting factor, anti-hemolytic factors, certain clotting factors that are required for people with bleeding disorders from it. So all these components, every laboratory staff should be trained on how to prepare them. Every laboratory staff should be trained on how to prepare all these components, because the method used in their preparation is just by centrifugation. All you need is a centrifuge. And so every laboratory staff should be trained on how to prepare to prepare these components. Fresh frozen plasma, is it packed red cells? Is it platelets? You should be trained to know how to prepare platelets. So I'm going to give the various components that could be prepared for it. So in the course of preparation, the laboratory personnel should keep in mind that blood should always be kept in a closed system. When it is coming from the vein of the donor, it should remain closed until it enters the vein of the recipient. You know, significant exposure to the air introduces blood to a lot of contamination, bacterial infection. So you go to people's blood bank and you would see that the blood is turning greenish. The plasma, instead of being straw colored, is turning greenish. Contamination, putrefaction, bacteria contamination. Why? Because people refuse to follow these basic criteria. They cut the blood open, put drops and do grouping and or expose the blood to the air and contamination setting. So closed system with minimum exposure to the environment so that you prolong the shelf life 35 days in the anticoagulants. So the standard components that could be obtained from blood is whole blood, packed red cells, and platelet. The platelet, maybe there are different kinds. You could obtain let me say, a plasma-rich platelet. These are all by centrifugation. Sometimes you could obtain a random donor platelet. A random donor platelets are platelets, maybe from one donor, the platelet is too small. When you centrifuge blood, blood comes into layers. You have the plasma on top, then the middle layer, a whitish layer, which is made up of buffy coat. And that is the layer where white cells, the leukocytes, and then the platelets are. Maybe one donor cannot give enough platelets for maybe you take buffy coat, especially from same blood group people, same blood group and resource people, and then they put them together. So random donor platelet or single donor platelets, that is fine. Then fresh frozen plasma, cryoprecipitate. These are standard ones. Every laboratory should be trained to prepare. And all you need is a centrifuge. All you need is a centrifuge. And in specialized conditions, people go ahead to prepare frozen red cells. Maybe there are some red cells, especially with the directed one. A relative is giving it to this person. Because of the condition of this person, you want them to store the blood for 10 years. You want them to store the blood for 5 years. So in that case, red cells could be mixed with a cryopreservative, a DMSO, dimethyl sulfur oxide, and you freeze it. Some requires that you wash their cells. So these are specialized ones that not every laboratory may be able to, but the standard ones. What equipment does the lab need in preparation of these? A weighing balance. So in your blood bank, if your facility has a blood bank, you should have a weighing balance for checking the weight. So some labs have it in the form of, let me say, a spring balance that they hook the spring to it and they check the weight of their blood in the blood bags. So you should have a refrigerated centrifuge. So a centrifuge that comes with an inbuilt refrigerator, so that some centrifuge, because of the centrifugation process, the spinning process, you are generating a lot of heat, and you don't want to heat your cells because we are maintaining it in a blood cold chain pattern. You are storing it at that temperature. So your centrifuge is 4 Celsius. It should be set. Okay. So every blood bank should have. I'm going to show you a picture of that centrifuge that has this bigger bucket that you could put your blood bags in them and then centrifuge. Okay. So these are equipment that that will be found in a standard blood bank. Tube sealers, because maybe you don't want to expose. People use scissors to cut their blood tube connected to the blood bag and dispense more and then tie it again. And you increase the risk of contamination in such practices. So that is fine. So if you centrifuge this blood bag, definitely the cells are going to settle, leaving the plasma on top. So segregation leaves these are component separation. So your buffy coat, the middle layer, which is made up of your white cells and your platelet, the plasma, which has your clotting factors in it. Sometimes within the plasma, you can centrifuge again, and obtain a cryoprecipitate that is rich in anti-hemolytic factors for administering to people with bleeding conditions, genetic ones, of course, then your packed red cells. So that is centrifugation. Yeah, that is for the purpose of component preparation. Blood bags come with satellite bags. So definitely blood bags, you see the primary bag. You see the primary bag connected to other smaller bags. These are called satellite bags, and they are there for a purpose. So the manufacturers produce them for a purpose so that when you take your whole blood into one, you could express the component of interest. Maybe if it has only one satellite bag, for instance, if it has only one satellite bag, so they come as double, the big primary bag and a satellite bag. So double, it has only one satellite bag. Maybe the packed red cells will be in the primary bag, and you can express the plasma in the other one. So sometimes they come as triple. The primary one and two smaller ones, triple. It's for a purpose. And sometimes they come in 4 sets. It's for a purpose, for component separation. So if you centrifuge and it separates, you can dispense one into one of the satellite bags. You can centrifuge that one as well and also dispense whatever component of interest. So these are pictorial display of the satellite bags that may come with blood bags. And they are all for the purpose of component preparation. Component preparation. So these blood bags must meet these international standards. So you can't, so if you are a lab man and you are involved in procurement, especially with regards to this blood, they must meet all these requirements. We can't just use any blood bag. You know, historically, blood were collected in bottles. Historically, blood were collected once in bottles, like minerals, like Coca-Cola and Fanta. Then, in the process of scientific and technological advancement, standards have been put in place that we should use these plastic bags, and these plastic bags must meet all these requirements. All these requirements. It shouldn't be opaque. When the blood is in, you should be able to see through. It shouldn't be opaque. It shouldn't be too transparent. So a bit translucent. You should be able to see through. It should be flexible. When you bend, it shouldn't break. Yeah. So these are all requirements of these blood bags that they meet. So every lab with a blood bank, with procurement, I don't know whether the private facilities may not be practicing that much, but even if they do, then procurement, they must make sure that their blood bags meet all these requirements. Okay, so that is fine. Now, if you want to prepare components from whole blood, these sealants are really important. Tubing welders, we may not find, I think all these may be present in only the regional labs or the regional hospitals, maybe where they do mass donation and then supply the other district hospitals with it. At the district level, and these heaters that are required to seal these tubings, maybe you dispense more for your grouping and whatever, these sealants must be there to seal them so that you ensure that blood is always maintained in the closed system. Otherwise, people would want to use scissors to be cutting blood. So this component must be present. And this is the kind of centrifuges that should be found in blood bags. Those with this bigger buckets where the whole pint of blood could be put in them for centrifugation. So for component preparation, you don't have to put your blood on a bench so that the red cells will settle. It takes a long time for the red cells to settle. Then you gently dispense the plasma off. No, there are centrifuges that must be done. That are provided to serve that purpose. Okay, so you centrifuge, it settles, then you express them. So there are expressors, equipment that expresses, that dispenses the plasma into the satellite bags, as you can see at the lower picture here. Then we seal it. So there should be sterile tubing weather to seal after expressing, to have expressed the plasma, to seal and to separate it entirely from the satellite bags. So that is it. So that is it. If you really want to prepare platelets are in the Buffy code. Maybe you have whole blood. Yeah. You have whole blood. You can express the plasma from it, including the Buffy code from it. You would have your red cells, packed red cells. So that plasma there has platelet in it. So we call it the plasma-rich, platelet-rich plasma. Yeah, we could spin it again. You can centrifuge that plasma again, and the platelet will be left on top. So you could express the platelet from it, and then have your plasma. And that plasma may be meant for, let me say, people freeze a fresh frozen plasma to help, with people with clotting factor deficiencies and that. Even with that fresh frozen plasma, we could also centrifuge it again. And then, have a cryoprecipitate that is rich specifically in certain specific clotting factor, anti-hemolytic factors and all that. So component preparation is not a difficult task. Once you have a centrifuge, you should be able to perform it. Once you have a centrifuge, you should be able to perform it. So these are to do that. So component preparation, red cells. If you store it in a normal refrigerator, 2 to 6 Celsius, what would be the shelf life of it? This CPDA, citrate phosphate dextrose adenine, is there to maintain a 35-day shelf life of it. So it could stay for that. That is fine. That is when you store it in a fridge. But if you add other additives like saline to it, saline and adenine, it could go to 42 days. That is fine. But if you want to prepare a plasma, fresh frozen plasma, those ones, they are stored in freezers, minus 30 Celsius, sometimes minus 20. It could be stored for up to a year. Yeah, so these are all storage, conditions, and then the shelf life that they could, be stored for. Cryoprecipitate, if you freeze it 1 year, that is fine. Platelets can, fresh platelet that you prepare, whether the random donor or the single donor, is for just some few days, and they need to be transfused as soon as possible, especially if you are storing them at room temperature. You need to transfuse them as soon as possible. So freezing red cells is also possible, especially rare ones, rare blood groups that people really, really struggle to get. After getting them, sometimes you want to keep them for long, and it's possible. If you put your red cells in a freezer straight away, you have hemolyzed the cells. You have hemolyzed it. They need to undergo extra step of preparation, because you are taking it into that cold environment. You need to add a cryopreservative, DMSO, dimethyl sulfur oxide. And in some facilities, last time I went to a fertility center, one of the facility centers in Accra here, and they deal with in vitro fertilization. This is a fertilization. They take people's sperms and then ovules. Sometimes the patients ask them to store it longer for them, because they want to be using it for the rest of their natural life. So they could store it for 5 to 10 years. So apart from even minus 20 freezing, some laboratory facilities have liquid nitrogen that they keep these blood samples. Liquid nitrogen is colder even than minus 80, and it could store your sample for even 10 years, and it is still wholesome. Liquid nitrogen. So it needs to undergo further preparation, a cryopreservative. Here, people use glycerol. That is fine. So, and you could freeze red blood, especially those with rare blood grouping. So, in event that you want to use such samples in specialized facilities like this, then you need to remove, because you added that aspect. Because if you transfuse it straight away, that additive is going to have an effect on the patient. So you need to wash the cells, washing of cells with normal saline and all that, to ensure that you don't transfuse people with this glycerol. That is fine. So, in our but that prolongs or maintains the shelf life for 35 days. So if you add other additives, it could go for 42 days. Now, storing blood, this aspect is really important. The fact that the blood is in your fridge is not a guarantee that every patient that blood will be good for every patient. Sometimes some patients require fresh blood, fresh as possible, especially newborns. Some people with some critical conditions, because it is the laboratory practice that in the blood bank, it is first in, first out. People practice FIFO, first in, first out. Oh, this one it came in first. It has been in our fridge for 28 days. It is getting closer to expiration. So when the patient is giving it, no, there are lesions that occur. Storage lesions. When you store blood for a longer time, certain changes, biochemical changes occur in them. And some of these biochemical changes may not be suitable for certain group of people. So some need as fresh blood, which is as fresh as possible. So lesions, sometimes, because of the anticoagulants and all these additives, and even because of the duration, the viability of cells decrease. The viability of cells decrease. If a donor gives blood, maybe 100% of the red cells are viable. But upon storing for some time, it can reduce to 70%, 30%. The fact that you see blood red doesn't mean all the cells are active. The fact that you see blood red color doesn't mean all the cells are active. So viability also decreases, and due to these biochemical changes. So biochemical and morphologic, changes occur when blood is stored. So what are some of these changes that occur? So the purpose of the preservative solution are to minimize the effect of these changes. That is why we have added a preservative. Yeah, to minimize it as possible. But as blood is getting closer to 20 days, 25 days, most of the cells are dead. They are not viable anymore, most of them. So at least 75% of the original cells must remain in the recipient's blood circulation within 24 hours or after 24 hours of transfusion. That means we have added a preservative, that is fine. But when we transfuse the blood to the recipient, at least 75% of the cells after 24 hours, they shouldn't hemolyze. They should be active. If it is for oxygen transport, they should be active in doing that job. So fresh as possible, yes, but the laboratory personnel should also note that changes occur and not all the cells become viable. What are some of these biochemical changes that may occur? Once you are storing blood at cold temperature, yeah, glycolysis and all that is taking place, and the red cells are metabolizing and all that. Know that some of the cells begin to hemolyze, some of them. So plasma hemoglobin begins to increase gradually. And some of these electrolytes, potassium, begins to decrease. Potassium begins to go down, begins to increase. Potassium is an intracellular cation. And it shouldn't appear in plasma. So potassium begins to shoot up a bit. The viable number of cells begin to decrease. The blood becomes more acidic. The pH is decreasing. So the more you store blood, the more acidic it becomes. Blood is slightly alkaline. The pH of blood is around 7.35 to 7.45, slightly basic. But once you are storing for longer, that is why I said certain categories of patients, newborn. So sometimes laboratory personnel should not be strict on the doctors. Sometimes they come that this is a newborn, I need fresh blood. It's my protocols. In that situation, because this one has come, is getting closer, I'm giving it to the newborn baby. They can't handle acidic blood. Their organs are not matured enough. Okay, and even this metabolite 2,3-DPG, 2,3-diphosphogylaceride, that decreases red cells' affinity for oxygen. It goes down. That means even the red, when the blood has aged 28 days, 29, 30 days, the red cells that you're even giving to the person, the red cells, their affinity for oxygen is really, really high. They can't even release oxygen to them. So it's not serving any purpose. For oxygen transfer, it's not serving it. This 2,3-DPG metabolite in their metabolic pathway is gone down. And that is important to decrease red cells affinity for oxygen. So those red cells are there, but when they pick the oxygen from the lungs, they will never deliver it. They keep it. So it's not even serving a purpose. So sometimes aged blood may not be recommended for certain group of people, especially neonates, newborns. Okay, so this chart is just to tell you that if you have this preservative CPD or CPDA, that's what we normally use. Yeah, and you are storing it at a cold temperature. Yeah, these are the changes that may occur over days. By research, people did that over days. So by 35 days, if it is whole blood, yeah, if you transfuse a person 24 hours, only 79% of the cells are still viable after transfusion. Most of them will be hemolyzed. So after 35 days, that is fine. And if it is 79%, it's good. It can serve its purpose. If it's red cell for oxygen transport, yes, it can serve its purpose. 79% of them are viable even after 24 hours of transfusion. That is okay. Yeah, that is why never give blood that has exceeded 35 days. It has expired. Viability of the cells. And a lot of these lesions have occurred. The pH and all that, have occurred. So that is it. Now, my final remarks, I'll talk about transport of blood components. Yes, you have gone through stressful process to obtain blood. You screen the donors, you've done all that, you have obtained the blood, you've taken your time in the blood bank to prepare all these components, you have stored it adequately. Yeah, so transport is also a very important aspect of it. When I say transport, I'm talking about even interdepartmental transport from blood bank to the ward or from one hospital to the other. Transport is really important. You should not break the cold blood chain. You shouldn't break it. Whole blood should be transported in a container that is cooling toward 1 to 10 Celsius. It is never allowed. You see, it is never allowed that a nurse will come from the ward with just ice chest, no ice pack, just ice chest. And the lab man will do his grouping, cross matching, and everything, and put blood in ice chest and give it to. And you have not followed the protocol. If anything happens, you see, one of the things that the nurses don't know is that you have given it to them. They are following their protocol. They're going to administer. If anything happens, they say it's from the lab because you give it to them. They don't know anything. And in event of this, that is where people are looking for who to blame. So the lab man should also be strict in terms of this. Maintain the cold temperature from your facility to where it gets to. When it gets to them and it gets to administration, they know what to do. They need to warm it up to 37 Celsius, at least to body temperature, to room temperature before they administer. That is their duty. But at your end, maintain the cold temperature. Okay, so ice that has not started to melt should not be used. Ice that has not, people take ice fresh from the freezer and it has not melted. There's no liquid on it. That ice, the moment you stick it to your blood bank, it is going to hemolyze some of the cells. Ice that has not started to melt, at least a melting ice is fine. For long distance transport, there's a special kind of ice known as dry ice. Dry ice does not melt. It evaporates. I don't know whether you guys have seen it before. Dry ice for long distance. Maybe you are taking the blood from Tema to Accra. You don't want to break the blood cold in dry ice. So you should always ensure that you follow that strict protocol. Frozen plasma products and frozen red cells, yes, it should always be frozen. Negative 18 Celsius. Freeze store practice is not the best. Maybe someone requested for fresh frozen plasma and let me see, O negative, and you brought it out and it thawed. Then they said, the doctor said we did it, now we don't need it again, so they are returning it. The thing has turned into liquid. and they brought it to you, then you want to freeze it back. Free store practice is not the best in clinical practice. Once you thaw it, it must go. It must be administered. Once it is thawed, it must be administered. So you have to always ensure that it is in that very cold temperature, minus 20 to 60. That is fine. So dry ice, there's a picture of it that could be used for the purpose of transport. Last time I had the opportunity to speak with one person who works in these renowned private laboratories in Ghana here. And it looks like they have depots in different regions. That is fine. Different regions. So their depot, you see, the name is a big brand. So when they take samples from one region, you may think they are running it there. They don't run it there. They take it to their main branch in one of the regions to run. It's a big brand. So you may say, oh, I'm going to, when they take the sample, they're not running it, they are shipping it. So I ask them, how do you transport it? Because this is interregional. How do you transport your samples? Because transport is really important. How do you transport it? Do you have dry ice? They said no. You don't have dry ice. In this hot weather, normal ice, by the time you stay in traffic and get to your destination, then the blood chain has been broken, rule has been broken. So transport is really important. As storage is also important. Make sure you don't break that temperature chain. So this comes to the end of my presentation with regards to blood component preparation and how to ensure that infection prevention protocols are also maintained. So at this point, I'll leave it to the host, and I would be ready to take any questions in case there are. Thank you so much.
Hello. Are we still together?
Hello, good evening once again. Thank you very much, Doc. We are very grateful for a wonderful delivery. Ladies and gentlemen, Doctor is still around. If you have any question, I think we'll leave the next 5 minutes for that to be done. So if you have any question, you can raise your hand and go on.
Cool.
Yeah, I think there's a hand. You can go ahead.
Hello, can you hear me?
Yes.
Yeah, thank you very much, Doc, for the wonderful presentation. My question is, I'm Sekaklos. My question is about the adenine saline. How do you add the saline to the? I just want to know how the adenine saline is being added as a preservative for that 42 days of blood storage. And two, if after you've finished the donation or donating the blood or taking the blood from the patient or the donor, do you have to put the blood straight to the fridge, or you have to keep it at the room temperature for a certain number of period before you put it in the fridge? Thank you very much.
Okay, Sekaklos, I'm really grateful for your question. Thank you so much. So, you know, these blood bags that come, their preparation is from manufacturers. So no laboratory personnel in Ghana here is allowed to do that preparation. All the additives, you are not allowed to do it. You are not allowed to do it. They come specially prepared from manufacturers. So based on the requirement from your lab, maybe to the best of my knowledge, CPDA, you buy it from the manufacturers and it comes prepared, sealed, because of, like, let me say, the potential of introducing contaminations in that sterile environment. There are these biosafety levels that there are some labs that may not be allowed to practice that. So if you want with that additive, adenine saline is from the manufacturers. So if you form part of the procurement team, yes, you could do that. Manually, citrate, phosphate, dextrose, adenine concentrations, even that one, no lab man prepares it. So they come in that blood bag set. So thank you for that. Now with blood storage. Yes, the more blood stays in room temperature. Yeah. The more blood stays in room temperature, the protocol says that you can allow it to stay for some hours, but it shouldn't exceed certain hours. So you shouldn't, there is no haste that as soon as I take it, let me rush and go and put it in the fridge. No, blood can stay on the bench for some limited hours. Then after that, it goes into the fridge. So maybe it shouldn't exceed 3, 4, 5 hours. It shouldn't exceed. But within that interval, that is fine. Then it goes into the fridge. The protocol doesn't say that immediately you take it, rush it, and take it in the fridge, maybe in less than 30 minutes. No, because it needs to undergo certain testing and all that. So it could be at room temperature for some time, so for some few hours. Thank you.
Thank you very much, Doc.
Eric.
Okay, thank you very much, Doc, for this presentation. It's very educative and informative. My question is, with the blood transportation, let's say your blood bank is not really far from the wards. You mentioned in your presentations that blood should be transported within a certain temperature range, 1 to 10 degrees Celsius. So I wanted to find out for proximity, where the blood bank is closer to the wards, and when you are issuing blood, you warm it at your lab and you transport it. At that stage, is it imperative to transport it once you've already warmed it for transfusion? Yes. So at that stage where it's not really far, is it still necessary that you transport it under that temperature range? Thank you.
Thank you so much, Derek. I'm really grateful. So the transport is a strict requirement that the blood cold chain should not be broken. So the blood leaving the blood bank should be maintained cold as it leaves the blood bank. So the warming is blood. I don't know whether now the protocol says lab men should warm the blood. It's not our duty to do that. It is the duty of the administrators, those who transfuse, to do that. So sometimes you see the nurse pouring water on blood, trying to bring it to room temperature. But the protocol is from your lab, it should be maintained cold. So the nurse or the recipient who is coming for it should come with a nice pack. That is the protocol. Then where they go, however you in for it, they should be documenting everything, because in event of let me say a casualty, they are going to screen every exercise that took place from transfusion and all that. So to look for who breached the protocol, that is where the legal issues will be taken from. So records, time that they are taking it from your lab, in your notebook, the temperature at which the blood was taken from and how it was transported. At least the nurses should sign. I'm giving it to you at this test. You witness this. It's in this. He should sign before he goes. And records should be kept. In another time, I'm going to tell you how we investigate a transfusion reaction, how we investigate. We'll come back to all these protocols to see where the problem came from. We'll come back to all these protocols to see where this, because they're going to check clerical, let me see, mistakes that people have done, written documentation. Is it there? Is it there? Then they read, no, here's where the problem is coming from. Before they even begin to think, oh, it was an antibody that reacted in the so it's not none of our fault. No, they want to know, is it the fault of the professional? So that is why we have to be strict in this. So proximity is at the ward, but I'm following my protocol. When you go there, they have to bring the blood to normal temperature and administer. They have to do that. Thank you, Philip.
Good evening.
Yes, please go ahead.
Yeah, I really enjoy your presentation. You have done very well. I want to know, when you're in the lab and you have done all your blood transfusion, you follow all the protocols, but still they send the blood to the ward for transfusion. But there is transfusion reaction. What other factors would have caused that?
Thank you so much. So transfusion reaction is a complex, it's a very complex situation that should require a lot of investigation, a lot. So I wouldn't use just this few minutes. Okay, you have done everything that perfect. Everything is perfect, but there's a reaction. So the problem could come. The problem could come from the nurse. It could come from the ward, not you. They brought a sample to you. They could say, we brought a sample from this patient, 2-3 samples, and sometimes they take and they mislabel on their way to the lab. Then they write, oh, I remember I took it from this one from this pregnant woman. This one, then they write, this is for the pregnant. They bring it to you. So maybe she might have swapped. ABO incompatibility. It is one of the serious ones. It's one of the serious ones. So it may be someone's mistake. That is the first step in investigating a transfusion reaction. The first step, whose mistake? That is where they want to know. So they'll be looking for records and everything to know, at least for documentation purposes. This is the blood you brought to me. The lab man said, when you brought it to me, I received, it was in the appropriate tube. Was it well labeled and all that? Yes, the lab man must confirm it was labeled, because you have the right to reject sample that is not labeled, that is not appropriately collected. The sample, if it is not enough, you have to reject it. So you accepted all that. Yeah. So you did your part. You did your compatibility, it was okay. But maybe it was a wrong person's blood that was brought to you. I mean, the recipient was wrong one. Maybe the person's blood would be, but they took it from the wrong one and brought to you. So if your records and everything says it's intact and all that, the blood was not contaminated, there's no bacteria coming on and all that, then they'll know that the mistake is coming from this person. Especially transfusion reaction, we have the rapid one, the instant one, the acute one. That happens. Maybe they put the blood on the person. Within few hours, the person is reacting. Those ones are mostly by mistakes, clerical errors, mislabeling, wrong sample given to another person. Those are ones are the most common ones. And it shouldn't be the lab man who is at fault. Maybe the nurse also brought a correct one to you, and the lab man did not check. Oh, the blood in my fridge, this one is labeled blood group A. So you think it's A. The fact that it's labeled A doesn't mean it's A. You have to always cross-check. You have to. So the fault should not come from the lab man. So one of the first steps is to check for clerical errors. Is there a mistake? If there is no mistake and everyone did is recognized, then that is when you are going to tell the nurse, we want to bring the patient, bring the blood you're transfusing, then bring, let me say, the initial blood you brought to me machine. We need that blood also. Then with fresh blood from the patient who is reacting. Is he having antibodies, unusual clinical antibody that is reacting to the causing it? Legalities are try to stay safe, so that he'll be exonerated. Thank you.
Any other question? Any other question?
Okay, so I guess there are no more questions. I apologize for the breakup in my earlier introduction. It was due to a network challenge. Thank you very much, Doc. Ladies and gentlemen, once again, I would want to say that registration is still ongoing. If you haven't registered, please do so immediately. And if you have a colleague or friend who hasn't done that yet, let them know that this is the last accredited CPD training. If you have not done it yet, please do the registration with us. We are open today, tomorrow, the 15th, and perhaps we'll close on the 16th. We shall have another session, God willing, tomorrow. The time will be confirmed to you by 12 noon tomorrow, as to whether we are having it at 3 or 5. I think the 5 is more convenient than the 3. What do you think? Should we maintain 3 p.m. or we should keep the 5 p.m.?
I think the 5 p.m. is okay.
The 5 is okay.
5 is okay. Okay. So we'll meet again tomorrow at 5. Thank you very much all for coming. I wish you all the best. Thank you. Bye.